Good afternoon. I feel like somewhat of an imposter, so I'm going to declare that at the outset. I'm an imposter because I'm an Australian speaking to a group of largely New Zealanders. I'm also an imposter because I'm a relative latecomer to drug and alcohol work. So I spent the majority of my career working with people with acquired brain disorders and injuries, including traumatic brain injury, stroke, dementias and so on. And I accidentally fell into drug and alcohol work. And it started about 6 or 7 years ago when Joe Lunn from Who's We Help Ourselves, a therapeutic community in Sydney, approached me and said, Jamie, we think that cognitive impairment might be an issue within our services. Would you please be involved in some research so that we can just do a prevalence study and see what the impact is, what the prevalence of cognitive impairment is. And since then, I've been doing more and more work in the drug and alcohol arena and enjoying it. So what I'm here to speak to you about today is a variety of approaches to the assessment of cognition within addiction services. So can I just get a show of hands of people who do formal assessment of cognitive functioning in your work currently? Okay, it's definitely a minority. I would imagine about 5 to 10% of you. And so that's a strange situation for me because I do assessment of cognition every day. That's my bread and butter. So what I hope to cover in this presentation is the fact that you can probably do cognitive assessment in a variety of ways, and you're probably already doing some of it. And I'd like to build on some of the concepts from David's wonderful address, and I think that ties in nicely with some aspects of what I'm here to speak to you about. So firstly, I'd like to acknowledge Joe from Who's and Who's the team there, Antoinette Sedwill from the Agency of Clinical Innovation, and I'll speak a little bit about some initiatives that we're collaboratively working on, and teams of researchers and students from Wollongong and Macquarie universities. So a lot of the work I'll be presenting has been collaborative with these groups. So first, let's just get clear on what the definition of cognition is, or cognitive impairment. So a cognitive impairment is a deficit in information processing. So just as your computers and smartphones process information and present that information in a particular way, so too does your brain process information. I particularly like David's point about filters. So our brains process information in very unique ways based on our experiences, our backgrounds, our mood at the time, and various other influences. And so cognitive impairment usually pertains to domains like memory. In fact, most people probably think of memory functioning when they hear the term cognitive impairment. So that's our capacity to encode, store and retrieve information over time. It includes attention and concentration. So this is basically our filter. Where is our spotlight focused on at any given time? How broad is that spotlight? And how much can we take in when we shine that spotlight on various things? Cognition also includes visuospatial skills. This is one that isn't necessarily front of mind, but it's about working with objects and appreciating spatial relationships between those objects. And then acting on those objects in certain ways. Cognition also includes language skills, verbal skills, and last but not least, executive functions. Who's heard of executive functions? Okay, so a few more of you have heard of executive functions, and they're very important, which we'll get to in a moment. Now, cognitive impairment can be defined in one of two different ways. One is deficits in these areas relative to the population norms, right? So if someone's average, above average, below average, we might say someone's got a cognitive impairment if they're a certain amount or standard deviation or 2 standard deviations below the average. But it might also refer to when someone falls from their baseline level of functioning, right? So it's quite possible that someone who started from a high baseline has had a brain injury, and so instead of performing in the superior range, they're now performing in the low average range, which population-wise is not, it's not bad, but it certainly represents a decline for that person. So this is how we define cognitive impairment. As many of you would know, cognitive impairment can be caused by brain injury, and in fact brain injury is the leading cause of cognitive impairment. But brain injury is a broad category. It includes things like traumatic brain injury, which is what the image up there depicts. And traumatic brain injury is defined as when a mechanical force meets the head, causing physical injury to the brain. So it's distinguishable from other types of trauma you might come across in your work, right? So trauma is often a term used to refer to psychological trauma. Here we're talking about physical trauma to the brain. And traumatic brain injury is the leading cause of cognitive impairment in the population. And traumatic brain injuries can be caused by assaults, motor vehicle accidents and falls. They're the main causes. Stroke is another common cause of acquired brain injury and tends to cause more focal deficits than we see in traumatic brain injury. Now, of course, at a drug and alcohol conference, all of you would be familiar with the effects of substances on the brain. And these can be short-term effects in terms of intoxication and withdrawal effects, but substances can also cause long-term cognitive impairment. Some of it can be reversible and some of it is irreversible. We know more about alcohol than the effects of any other drug, and that's more or less a good news story, because if someone can reduce their alcohol consumption after harmful use, then there are good chances that they can regain some cognitive skills over time. And that's dependent on a number of factors, such as the age of the individual and for how long they've been using the substance. So they're very common and obvious causes of cognitive impairment, and some less intuitive, I suppose, causes include mental illness. Now, mental illness, particularly severe mental illnesses, so schizophrenia and psychotic illnesses in particular, are associated with cognitive impairment. And the impairment that's measured in those populations is equivalent to that of moderate to severe traumatic brain injury. So we're talking about roughly the same degrees of magnitude of impairment. But of course, those impairments are not caused by the mechanical force hitting the brain. They're caused by some neurodegenerative changes at the cellular level. In the case of schizophrenia, that usually has its onset during adolescence. And so the synapses start to lose connections, which then results in cognitive impairment. And then and I'm basing this on the workshops I've conducted across the country, very generously supported by Montreal. And the final one is one that people often don't think of when I ask this question during the workshops, and that is learning disabilities and developmental conditions. They're not front of mind as causes or sources of cognitive impairment, but they are. In fact, they're defined by virtue of impaired cognition in various aspects. So with learning disabilities, like the dyslexias and reading disorders, the most common type of impairment is a working memory difficulty, right, where a person struggles to hold information in mind whilst manipulating it. So when we do mental arithmetic, for example, we're using our working memories. And people with learning disabilities struggle with this. Another common one that you would come across, which is at very increased rates in drug and alcohol services is attention deficit hyperactivity disorder. How many of you have come across individuals with known or suspected diagnoses of ADHD? Almost all of you. That's no surprise. Now, ADHD has an interesting story. Whilst it's called attention deficit hyperactivity disorder, when you do cognitive testing on large groups of people with ADHD, sure, there are some attentional problems, but there are also some memory problems, but most significantly, there are problems with executive functions. And it's so much so that there was a group lobbying the DSM-5 that wanted to change the name from attention deficit disorder to executive function disorder, because the frontal lobe functioning, the executive skills are so impaired for people with ADHD, such that they can't easily plan, organise and regulate their behaviour. So these are important causes of cognitive impairment in the people that you service. Now, why is cognitive impairment so interesting within drug and alcohol services? Well, we've known for a quarter of a century, actually, that it's one of the strongest predictors of failure to benefit from drug and alcohol treatment or relapse. And that's particularly the case when there are executive function disorders. A recent systematic review highlighted that one of the most important factors that predict dropout from addiction services is cognitive impairment. And the other two factors are being younger and having a personality disorder, and the authors speculate in this paper that those other two factors are probably related to cognitive impairment anyway. Because if a person's younger, they haven't yet developed their frontal lobes fully, and therefore they don't have those executive skills. And personality disorders are associated with cognitive impairment. So it's a very important construct to understand and to assess in some way when you're working with people in addiction services. But another thing that's important to ask yourself before knee-jerking to let's measure cognitive impairment is, why do you want to measure it? What are the purposes of assessing it? And there are multiple purposes. Now, in hopefully the old school paternalistic medical model, often the purpose was something like this, right? To do something to the patient, to manage their behaviour, right? So a very impositional model, very contrary to what David's been speaking about. Non-inclusive, I'll implement this on you. And regrettably, sometimes in some settings, that is still the reason why cognitive assessments are requested. Hopefully we've moved more towards a recovery and therapeutic model, and if we're thinking of assessing cognition, that we would ultimately be doing it for therapeutic purposes, to help that person that we suspect has a cognitive impairment. So it could be simply that once the person knows what their cognitive strengths and weaknesses are, then they're empowered to do something about it, to change their life in some way, to compensate for the weaknesses and utilise their strengths more often. And that doesn't take much. That takes an assessment and a feedback session to achieve that therapeutic aim. And sometimes the aim is a little bit more involved, and this is the sort of work I do regularly, cognitive rehabilitation. So there's an over 100-year history of well-researched, empirically validated tools and techniques that can help people improve their functional cognitive skills once that's been identified reliably. Another purpose for assessing cognition might be to screen clients in and out of various programs, and in Sydney there are some services that are dedicated to helping people with cognitive impairments, and so they need some way of screening people in and out of those services. And another one that is probably in the forefront of your minds pertains to decision-making capacity. I was saying to someone at lunch today, I've never formally been asked to speak to SACAT, but I often get asked questions about it. And so this last point was me preempting that. And the assessment of decision-making capacity is a very pure cognitive assessment, because it's hard to observe the impact or to observe decision-making capacity outside of the scope of the impairment level of cognition. So, how do we assess cognition? Most of you would probably be thinking, testing. You give cognitive tests, it makes sense. So cognitive tests are what may be referred to as performance-based measures. This is when a person is asked to do a task, and that task is measured in a standardised fashion. The task might be to remember a list of words, or to remember some short stories, or to perform some mental manipulation. And there are many cognitive tests available, some of which you need extensive training for, some of which you don't need extensive training for. And that is seen as the gold standard of assessing cognition for most people, but I'll make an argument against that at the end of this talk. Another way we can assess cognition is to simply ask people about their cognition and related variables. How many of you already do that? Not very many. So that's a very simple tweak you can make to your services, which is a reliable and valid way of ascertaining some information. And again, it's in line with a more collaborative approach to assessing the situation. And finally, observing behaviour. Just observing everyday behaviour is another way of giving you clues as to what's going on at a cognitive level. And ultimately, when we're interested in measuring cognition, there is some behavioural goal. There is some either proximal or distal behavioural goal. And these things lie on a continuum. And so cognitive tests assess cognition at that impairment level. They measure the actual brain function in terms of how well organised how well organised is the brain and how good is it at functioning for this particular skill. And the other end of the continuum is the ecological or the real world level, right? And there's a vast distance between those two extremes. For example, someone might appear to have a memory disorder because they can never remember to turn up to appointments on time. Well, that might be because their brain's not processing information related to memory correctly, or it could be that they're stressed or anxious about something, right? It's still a brain variable, but it's not that primary cognitive skill that's impaired. And so at the real world level, there are functional cognitive difficulties that may not show up on testing, and that actually happens often. So cognitive testing is good at measuring what's happening at that impairment level. It's not necessarily great for predicting real-world behaviour. And I'll say a little bit more of that in a little while. So as far as behavioural observations go, right, the lowest level, if you like, or the simplest entry point at assessing cognition, you're going to have your filter on when you're observing behaviour, and you're going to interpret behaviour in a certain way. And I've observed this in my practice, and I've heard about it from other people's practice, in that certain behaviours are attributed to certain motives or intentions, whereas all along it might be that the person's not processing information correctly. So if someone is easily distracted, for example, right, in group sessions or individual sessions, they just can't keep focused. again, hopefully an old school interpretation might be, well, they're not focusing because they're just not invested. They don't care. They don't want to be here. But a cognitive impairment-informed interpretation, and I made up that term, by the way, might be that the person actually struggles with focused and sustained attention. And if we just know a little bit about their history, we might discover that they have ADHD or brain injury or both. And just that knowledge that there might be a neurobiological cause for this behaviour can actually help shift your lens of interpretation, which is a good thing. So behavioural observations can give you some insights into what's happening cognitively, but it can also lead you astray. So it's one you need to be careful of, but I would encourage you to refine your skill at linking behaviours, observable behaviours, with possible or probable cognitive impairment. And it's probably something you're already doing and you're already good at doing, working in addiction services. Another example might be if a person's not picking up or retaining basic information. The old interpretation might have been, well, they've got other priorities. Again, they're not interested, they're not invested. Or it could be that they have attention span or memory or working memory problems due to a specific learning disability or a brain injury, and that's the barrier. Similarly, I've heard this one quite a lot. If someone struggles with the reasoning process or a negotiation process, often the interpretation is, well, they're just being difficult, right? They're deliberately doing this. And the moment you have that interpretation, that already puts you into a frame of mind that's probably going to be judgmental and unhelpful. Rather, it could be that the person is struggling with reasoning because they have executive function deficits, which would make reasoning very hard, and they might have had a brain injury. So what I'm suggesting here is certainly allow behavioural observations inform you of whether or not there may be cognitive impairment, but closely guard your interpretations of the behaviour and shift your interpretations, if appropriate, when in receipt of alternative, more viable explanations, such as a history of brain injury. So that's one level where we can do some assessment. The pros are it's the most ecologically valid level of assessing the impact of cognitive impairment. You don't need formal training, but certainly experience helps. And you don't need any instruments or equipment to do that. The cons, of course, are it's highly subjective. It's not a standardised approach to assessing cognition. The validity of that type of assessment is almost entirely dependent on the experience of the observer. And there are many different possible causes for the same behaviour. So it's something you can refine over time, and I would encourage you to do that within your own reflective practices. If we go then to the next level of detecting cognitive impairment, self-report. Now, self-report can pertain to two different components. It can be self-report about symptoms, or it can be self-report about history. And this is something that we're currently investigating in research, and what we're actually looking for is predictors within a person's history, their self-reported history, together with their self-report of symptoms, predictors amongst that set of information for actual performance-based cognitive impairment. Now, I imagine all, or at least most of you, would have in your intake procedures and protocols questions about head injury. Is that the case? Yep, it is. Put your hands up if you will routinely ask about that. Excellent. And when you ask about head injury, you're asking about loss of consciousness. Good. And are you asking about hospitalisation following head injury with loss of consciousness? Yes? So who is asking about all of those things? Okay, so looks like about half of you. I'm going to make an argument that it's really important to ask all of them. And the argument goes like this. So in that initial research that I did with WHOS, we administered the Montreal Cognitive Assessment, the MOCA, which is a cognitive screening tool, to all current residents of the therapeutic community. So we had a good size sample of 128, and we compared their results on that test to a group of 37 controls. And what we found in that research, which I've presented last year, is that 44% of the clients met criteria for cognitive impairment. So almost half, on a performance-based measure, had cognitive impairment. They were in the range where you would normally suspect an older person of having possible dementia, right? So we're talking about quite significant impairments. But another thing that came out of that study is the base rates or the prevalence rates of the next two phenomena. So 2 out of 3 of those clients had a history of head injury, of traumatic brain injury, because they had a head injury with a loss of consciousness. And 50% of the clients had a head injury that was severe enough to warrant hospitalisation. And we found that having a head injury was a significant predictor of cognitive impairment within this population. And so this is a graph from that article that was published last year. And what you see there is the different domains of the MOCA. So you've got executive and visuospatial functions, pure executive functions, short-term memory, working memory, visuospatial abilities, and language. And we found out of all of those areas, executive function impairment was the biggest predictor the history of head injury was the biggest predictor of executive function impairment. And that's relevant because that's the main type of impairment that we observe in addiction services. And as you can see from the graph, the non-hospitalised individuals with brain injuries were performing worse than the controls, and those that were hospitalised were performing a lot worse than both groups. So hospitalisation following head injury with loss of consciousness is going to be a significant predictor of cognitive impairment, and if you don't have the resources or skills or time to do cognitive testing, this is a good shortcut to ascertaining whether or not someone possibly or probably has cognitive impairment. And those data about executive functions being particularly impaired are consistent with what we know about traumatic brain injury. So what you see there is the lower half of the inside of the base of the skull. The upper half is relatively boring because it's just smooth inside, but you can see in this image there are lots of bony protuberances at the base, and the top of the diagram is exactly where the frontal lobes rest. And so when a person experiences a traumatic brain injury, the brain rocks around inside the skull and the brain presses up against those bony protuberances and gets bruised. And so the bruising is mostly, I don't have a pointer, but in diagram A, it's at the bottom there, and diagram C is the base of the brain. So if you're looking at my brain, it's that way. And as you can see, most of those bruises are happening in the frontal lobes and at the base of the frontal lobes, and that's significant because that's more or less our control centre, right? And if that's not working well, we lack self-control, we lack discipline, we lack the ability to regulate our behaviour. So asking about that history is important. The other thing we're doing in research at the moment, and I was hoping to have some results to show you, but the results are a little bit premature, but we're looking at other variables, including history of overdose, because of course that raises the risk of a hypoxic brain injury. so injury to the brain from lack of oxygen. We're also looking at other neurological factors which we're not seeing in very high rates within this population, but it's worthwhile looking at them anyway. We're asking questions about fetal exposure to alcohol and other drugs and seeing whether that predicts cognitive impairment, and whether or not a person's had a history of learning or behavioural difficulties at school, to capture particularly those who are more severely impaired with learning disabilities and or ADHD. And so we aim to publish this research, of course, and ultimately develop a screening tool, more or less a checklist that you can go through, so that if you've got a certain number of these variables, there's X chance of this individual having a cognitive impairment. In the meantime, it's probably worthwhile asking these questions because it will inform you, it will give you a little bit more context about the people that you're working with. So that's self-report about the person's history that may inform assessment of cognition, but you can also ask them about symptoms, and the simplest way to ask about symptoms is this, and this is part of our screening battery. Do you experience memory or other thinking difficulties? Right, just a straight out question. In the small group that we've piloted this with, 86% say yes. So that's not necessarily very helpful. That's a lot of people. It's slightly higher than the actual rate of cognitive impairment in this population. So there are probably some people who, in their minds, are viewing themselves as having the impairment when they don't actually have the impairment. But that's could be seen as a good thing. It shows at least there's a good degree of insight within this population. So to supplement that question, or to be a little bit more precise about a history of subjective complaints, another option available to you, to all of you, is to use standard questionnaires. How many of you use standard questionnaires to ask about subjective cognitive problems? Okay, again, very, very small minority. Again, if you're not used to assessing cognition and you want to do something, this is another really easy point of entry into doing more formal standard assessment. And I'll speak you through a few of the more popular scales and the ones that we've used in our research. Has anyone heard of the Cognitive Failures Questionnaire? Okay. Some? Okay. I wouldn't expect you to have, but it's used extensively in the brain injury literature. It's used extensively in the mental health literature. It's something of a gold standard with respect to assessing self-report of cognition. It includes 25 items, such as, do you start doing one thing at home and get distracted into doing something else? Do you find that you forget people's names? Yeah. And the rating is made on a 5-point scale from never to very often. Now, some of you might be a little bit concerned, but the maximum score is 100 and there are norms, right? So the average score is about 30 or 31. So it's okay to say yes some of the time to some of these items. And so in our research, based on 141 participants, we found a large and significant difference between the score, overall score on the CFQ, relative to the normative healthy community sample, with the difference being almost 2 standard deviations away. So for those that understand statistics and psychometrics, that's quite a large effect. It takes 5 or 10 minutes for someone to complete the CFQ. If they're literate, obviously they can just do it themselves. And if not, well, that might be 5 or 10 minutes out of your day to read the items to the person. It's free, it's in the public domain, so virtually no barrier of entry to using this to detect self-reported cognitive impairment. Another scale that we've used in our research is the self-control scale, and we use the brief version of it, which is just 10 items. So it's very quick. This takes about 1 minute or 2 minutes. And it includes items such as, I often act without thinking through all the alternatives, and I have a hard time breaking bad habits. Now, some of you might endorse some of that some of the time. And again, it's a 5-point scale from not at all like me to very much like me. And the final score is divided by the number of items ranging from 1 to 5. 1 being not at all self-controlled to 5 extremely self-controlled. And again, we're finding significant differences between a residential AOD treatment client group and undergraduate students, which may lack self-control by virtue of other things. So if you want to get, and these are reliable tools with good psychometric properties, and so there are a couple of tools you can add to either your intake processes or just your toolkits if you're interested in assaying whether or not someone's got a cognitive impairment without having to develop the skills to administer neuropsychological tests. And another one that we've used a lot in our research is the Brief A, the Behaviour Rating Inventory of Executive Functions. Now, this has some user qualification restrictions. So you need to have a degree in psychology or related discipline and training in psychometrics to administer and score and interpret this. So it's a longer instrument, 75 items, with a couple of examples of the items there. It's only a 3-point rating scale. So over the past month, how often has this applied to you? Never, sometimes, or often. And then the raw scores are converted to T-scores. And we're getting, again, very significant differences with our average score in our clinical sample within the impaired range compared to the normal sample. So all of this converges, right? So we're dealing with a population with very high rates of traumatic brain injury, very high rates of cognitive impairment, and when we ask them using these self-report measures whether or not they've got cognitive impairment, they're reporting results in the expected direction. And so this is a valid way of assessing cognition, short of doing cognitive testing. So the next section, so the pros and cons about self-report. The pros are it provides valuable information about the client's self-appraisal, about their knowledge about their cognition, which can indicate their level of insight. It's a cost-effective approach, and it allows you to compare results to norms. Self-report scales have good ecological validity as well. So there are some situations where the self-report scale score is high, so in the impaired range, but then when you do cognitive testing, the person scores normally. And so there's real value in using this approach. The cons are there's some subjectivity on the part of the client, and therefore it's potentially unreliable. Some clients may be inclined to exaggerate in either direction, making themselves look better than they are or worse than they are. If someone's got literacy issues, there might be compromised validity. Now, when it comes to cognitive tests, many of you would have heard of the mini-mental status examination. I've trained some of you in how to administer and score and interpret the MOCA, so that's another abbreviated screening tool. And you don't need any particular qualifications, but it's recommended you have the training if you're going to administer the MOCA. And MOCA now provide online training at a cost. Some of you use the Wechsler tests in your assessments. The Stroop Test is another test that some of you might have heard of. So this is an item from the MOCA that assesses cognitive flexibility or divided attention. So the object here is to draw a line from 1 to A, then to 2, and keep alternating between number and letter. And so a person who fails on this item might be said to have difficulties with cognitive flexibility. They get stuck in a line of thought and find it hard to shift their line of thought. Some of you would have seen the Stroop Test, and this is where there's various iterations of this test, where a person reads words that are written in different coloured ink. So in the first column there, the colour of the ink is congruent with what the word says, and in the second column, it's a lot harder to name the colour of the ink because your automatic response to read the word gets in the way. So what you need to do here is inhibit that automatic reading response in order to do the task, which is to name the colour of the ink. So these are examples of performance-based tasks or cognitive tests. Now these have pros and cons. Obviously the pros are their precise ways and more objective ways of assessing an underlying cognitive construct. And impairments can be detected even when the person you're assessing is unaware that they've got an impairment or are unable to describe the impairment. And you can get an idea of the degree of the impairment. It's not an all or nothing thing. On the con side, and this might surprise many of you, cognitive tests are not very ecologically valid, right? If you're going to base your opinion about a real world phenomenon purely on test results, you're going to be wrong more often than you're going to be right, because you can't summarise the complexity of human behaviour in a test score. And the other reason why you're going to be wrong often is there are many people, some of us in this room, including myself, who are aware of our cognitive limitations, and so we compensate for them, right? We use Google Calendar or we set reminders. Now, these are all functional, positive behaviours, which allows us to get by whether or not we have cognitive impairment. But the biggest con for cognitive tests is you do need a high level of training generally and qualifications to administer. And there is a risk of harm through misinterpretation. Now, I've realised I'm quickly running out of time, so I'm going to quickly talk about neuropsychological assessment. I know it's a rare resource within this country, as it is within Australia, but often people equate neuropsychological assessment with cognitive testing, but it's not. In fact, sometimes you can do a good neuropsychological assessment without doing any testing, because sometimes testing is inappropriate. Neuropsychological assessment incorporates all of the levels we've discussed. It incorporates close behavioural observations, self-report of symptoms and history, and cognitive testing to formulate a holistic opinion about what's going on, and it includes a relevant review of the relevant documentation. So I'll quickly run through those pros and cons, but basically it's a limited resource is the main con here. And because I said I would say something about the SACIT, I'll very briefly touch on this, and that is decision-making capacity is an important assessment to make. It's under SACIT, I understand it needs to be done by an approved specialist. And that's because we have a duty as a society to protect people against the harms that may arise out of their incapacity to make decisions. And the SACIT stipulates criteria for impaired decision-making, which are a person may lack decision-making when they're unable to understand information that's relevant to their decisions, to retain that information, or to weigh up the pros and cons appropriately, and then to communicate the decision. And of course, all of these are cognitive constructs. And in an ideal world, you would have a neuropsychological assessment every time you do a capacity assessment, but sometimes it's inappropriate, as I said, to do testing. Examples that were raised with me at lunchtime today include if someone's intoxicated, well, it's not going to be appropriate necessarily to do testing. And so to do a good decision-making capacity assessment, it's important that you ask questions about those criteria, so through an interview process. And then the testing and the behavioural observations will then give you clues as to which of those domains are likely impaired. And then if you know which domains are impaired, you're going to be in a much better position to help the person restore their decision-making capacity, which is another aspect of the SACAT bill. But I appreciate I've run out of time. So just very quickly, I want to recap that if you're thinking of assessing cognition within your services, ask yourselves, why do you want to do it? And if you don't have the skills or resources yet to do so, there are a range of options which are valid and simple as a barrier point. And very quickly, the Agency of Clinical Innovation and myself and WHOS are involved in the ACE project, so the Alcohol and Drug Cognitive Enhancement project. And what we aim to do is to make available to drug and alcohol services screening tools, both self-report screening tools and performance-based screening tools that are accessible for all drug and alcohol workers. But we're in the process of validating those tools at the moment. And then the other important aim of what we plan to do with ACE is to develop interventions once cognitive impairment has been identified. So we've already done a pilot in a psychoeducation intervention, and we've just got results in for the randomised control trial of CRIDUS, which is our cognitive remediation intervention. And I'll be speaking about some of that at the workshop on Saturday. Thank you.